Hello, everyone. Welcome, welcome. I hope you can see me. If you can, you should be able to see both me and Usmaan. Then just give us a thumbs up in the chat. Or just say yes. Hopefully you can hear us. Okay, perfect. We'll be starting literally 1 minute. Sorry for the slightly slow start. Okay, I'm hopeful you can see my screen. For those of you that don't know me, my name is Shoaib and I'm one of the course organizers for BitePACES. I'm a doctor based at London, Guy's and St Thomas's Hospital, and as I'm sure most of you are probably aware now that we run the BitePACES course. And just before I hand over to Usmaan, who is our course lead, and is going to take you through some wonderful clinical consultation cases, I'm going to very quickly touch on the course. We're fast approaching now, and we have our first course coming up in just over 2 weeks. And we have a 4-day and a 1-day option. And, without taking up too much of your time, I think what we really pride ourselves on is the small group teaching. We try and keep the groups down to just 2 of you, and we try and ensure every patient is accompanied by a course instructor to really give you that intense teaching. We've had great feedback. We've taught hundreds of candidates over the past year and a half. And I'm looking forward to seeing more of you at our future courses. So if you head over to bitepaces.com, you can find out more. And, if you're not interested in the course, that's absolutely fine. You're welcome to join our WhatsApp group, which is there at the bottom right, that QR code. And that's where we post everything about our free webinars. And I'll try my best to answer your questions on that WhatsApp group. For those of you that attend the webinar, you have a £20 discount and the code is there. And sorry, these prices are actually the early bird prices. I haven't updated them. The prices have since gone up. What I'll say is that we probably only have a handful of tickets left for September, and I'm literally talking about maybe kind of 3 or 4. So if you are interested in attending the September course, please try and book your tickets in the next 24 hours, because I may have to close sales if I can't find more space, basically. And we still have some space in our October course. So yeah, check us out. Some feedback from previous courses, plenty of people messaging in saying they passed, someone got 100%. Google and Trustpilot feedback's all very good. And it saddens me to say that we're coming to the end of our webinar schedule today. This is our 3rd schedule, and we've run a total of 9 webinars, mainly focusing around the things that you guys have said you wanted in our WhatsApp groups, the clinical consultations, cardiology, neurology. We've done some RESP and some general preparation tips. All the recordings are on our Google Drive, which again can be accessed via our WhatsApp group. So please do join. And without further ado, I'm going to hand over to Usmaan, who's an allergy and immunology registrar at Addenbrookes Hospital. He was a former medical registrar at Guy's and St Thomas's, and he is our course lead, and he's going to take you through what I hope is going to be a really interesting and productive session. So, Usmaan, I'll hand over to you.
Thank you. Thanks, Shoaib. Okay. So let me just share my screen. Can you all see the screen?
Yep, I can see that.
Perfect. Wonderful. All right, great. So I'm Usmaan, as Shoaib said, and I am going to be doing a session on clinical consultations today. We've already talked about this. As Shoaib said, sign up, tickets are going fast, and it's an excellent course, which we think will be really beneficial to you guys. We've recruited some excellent patients, and yeah, sign up if you haven't already. So we're going to just talk through some clinical consultation station tips and then do some cases. Let's start with just what the clinical consultation is like. You may or may not already be aware. So it's 2 stations now, 5, and there will be 1 acute case and 1 less acute case, is what they've said. Generally, you'll get a short note or a letter from like a GP, for example, to review a patient who they've seen with like a little blurb about this patient. And you get 5 minutes to review the information, 15 minutes with the patient, and then 5 minutes Viva time. In that 5 minutes beforehand, when you've got that piece of paper, you get your own paper to write on and just jot down. The main thing you want to be jotting down there is differentials, because your history, which we're going to talk about in a second, is what is going to get you the answer, really. And so as long as you've got the correct differentials in mind, you'll ask the right questions in your history, and then think about what examinations you're going to want to do based on the little blurb, because really from the 2 lines they give you, you already know, like, these are the kinds of things that I'm going to examine. And the discussion, you're not really going to be able to think about at that point, really. And then you'll have the 5-minute Viva at the end for Q&A. I think in the past, when this station was different and shorter, there was a tendency to put in spot diagnoses, so like scleroderma or rheumatoid arthritis, just to see if people could get it, or like the weird and wonderful things. I think it's good that they've changed the format to try and move away from that. And so now, if somebody has, I don't know, acromegaly or something, rather than all the points being for getting that spot diagnosis, the station is much more likely to be complicated by this person already has this chronic condition, or their chronic condition is not yet diagnosed or whatever. Please think about the complications of that. So for example, it's much more likely to be like a rheumatoid arthritis with new ILD than just somebody who's got new rheumatoid hands, because that's just a lot more faffing. And I think they're trying to move to a place where you can be more holistic in your answer to this station in the way you would be in as a med reg, because that's what they're trying to make good med regs. Fine. And so the task is always the same, these 4 things. You need to elicit you basically need to do a history and examination, advise the patient of your diagnosis, answer their questions, and then you would then have the Viva at the end. And the setting will generally be either like a medical outpatient clinic, medical ambulatory care, you've seen this person on the medical take in MAU, or a ward review. So like a surgical patient who's got this incidental thing, can you please review them? And I think the other thing just to flag is that you could either be taking the history from the patient or from a surrogate. And so if anybody's doing the exam abroad, often the history will be taken from a surrogate. And this is important because when you're then doing the last part, which is the explanation and answering questions, it's just important that you know who you're addressing it to. So if, for example, you are taking your history from the child of somebody who's got dementia, for example, then all your questions and your explanation are going to be targeted at the surrogate. And I think generally the way that this station will work is if there is a surrogate, all the conversation will be with them. The patient is literally just there to be examined. So just remember that when you're doing when you have these stations. Next, in terms of timing, so you have these 15 minutes to do all of these different components of this station. And as I said before, the history really is the most important, because that's where the answer is going to be, almost certainly. So the most time should be spent on the history, 5 to 8 minutes, depending on how obvious or not obvious it is. Then examination should be less, so 2 to 4 minutes. Your examination can be really focused, and we'll discuss that shortly. And then leave 4 to 5 minutes for discussion. They give you this bell with 2 minutes to spare, if at that point you haven't started going through your investigation, your plan with the patient, then you need to quickly move there because that's a bit late. And really, if you've got a watch on you and you should be aware where there's a clock in the room, then with 4 minutes to go, you should have moved to discussing with the patient, because a lot of the marks in this station are for how you discuss, whether you can communicate with a layperson and explain a plan and answer questions and allay patients' concerns. So just please remember that. I think people can get really bogged down in trying to find the correct thing on examination. Just remember that, number one, there may not be anything to find on examination. I think in both of my station fives, the examination was really bland. There was nothing. And so don't get bogged down in it, because the marks are more for the discussion than they are for the examination. Obviously, you don't want to miss the really obvious thing, but we'll come to that in a second. In terms of history, you all know how to take a history, so I'm not going to, flog a horse. But I think that the key thing that people miss is the social history, because there will be marks in that and there will be important parts in the social history that will feed into the answer. And even if they don't feed into what the diagnosis is, they'll feed into the ideas, concerns, and expectations of the patient. So when you're practicing this, please remember these parts of the social history that you should ask for all of the patients in this station. Because they know that the station is quick, they're not going to give you long, detailed answers. So don't worry that it's a lot of questions. Like it'll be, do you smoke? No, never. Do you drink alcohol? Yeah, once a week. There'll be quick answers. So I know it seems like a long list in social history, but it's important. So I would definitely try to ask them and just have that in the back of your mind. They have tried to make it so that these stations now, their past medical history is not very complex. And so again, the bulk of your marks are going to be in the history of presenting complaint and then taking a detailed social history. And then at the end of your history, so before you examine or when you're about to start examining them, you need to ask them, is there anything you're particularly worried about? Because that's really key and that will help you. In terms of examination, so your examination is obviously really focused. And I know it says in the mark scheme and it says in various places that you don't need to finish your history before you start examining. And that's true. You're not going to get marked down if you do that. Personally, I think that it's hard to think of two things at the same time in an exam situation. And so I would really try and quickly finish my history in the 5 to 8 minutes and then move on to the examination, because your examination is really focused. But if you look at the mark scheme, they want it to still be structured, which I think is a bit of a strange thing to add. So the way that you do that is you just try to follow your same routine, but skip the things that are not useful. So generally, you're always going to start at the hands. Maybe you'll feel their pulse. We'll talk about some of these in a second. And then go to their face, then chest, abdomen, and then neuro at the end. So I think that's it's a good way of keeping it structured, because they will like that structure. And if there's any, and like I'm not saying you need to listen to everyone's chest, because obviously you don't, but if you just think that I'm going to start at the hands and work my way around like I would in any other exam, then it will make the examiner feel at ease, because these examiners are, quite tense people. So if we just have a think about these ones, you can write in the chat or you can shout out. So for if the station was quite clearly, or you thought it was someone who'd had a TIA, what things would you want to examine? Yeah, carotid bruit, good. Pulse, yeah, looking for AF, fantastic. Endoscopy and neuro. So neuro is a big thing though. So when you say neuro, what do you mean? So I think all of these are good answers. Wonderful. So I would say in terms of timing, you're going to go for pulse, carotid bruits. So if we go around, pulse, carotid bruits, heart sounds for murmurs, and then the things that are left on neuro. So in terms of doing a brief neuro exam, because really you don't have time to obviously do a full neurological exam. So brief neuro exam is gross power in all four limbs, because they've had a TIA, right? So they shouldn't really have any neurology now, because in the history you've elicited that their neurology is resolved. So you're just making sure that you're not missing something. So gross power exam. So just general pull me towards you, lift your legs up or kick your legs. So you're doing like compound movements. You can do pronated dift if you would like, and then face. So visual fields are really important. And I wouldn't do reflexes. You could do planters if you liked, if you had the time, but I don't think it's like an important thing. You're going to miss something because really the planter should have resolved by now. And then facial expression. So I would do pulse, carotid bruits, heart sounds for murmurs, power in all four limbs, visual fields, facial expression. That should be sufficient. Someone mentioned fundoscopy. I think if you can avoid doing fundoscopy in any station, I would avoid it. I don't think they're going to expect you to do it in TIA. I know, like if you have amaurosis Fujax, that's a nice thing to offer. And maybe you can offer it in your Viva, but you're not going to be faffing around because you don't have time. Then for palpitations, if they're complaint with palpitations, what would be the things that you're thinking about examining? Wonderful. Yeah, good. So everyone said pulse. Good. I would hope you would all say pulse. That's obviously very important. Someone's got palpitations, make sure they've not got any gross arrhythmia AF. Look for a tremor when you're doing your pulse in case they've got thyrotoxicosis in the thyroid. You can feel for a goiter, and then heart sounds for murmurs. And then so in terms of thyroid status, so you've done tremor and you've done their pulse. So that's basically if they're thyrotoxic, you should have got it right. If they look very sweaty, that should be enough. You'll always get the blood pressure, Tareem, in the observations at the beginning, so you already know that. You'll look at their face. I wouldn't spend my time looking over their head and looking to the side, unless it's really clear that you think that they've got exophthalmos. And then the last thing would be also to look for signs of fluid overload. So especially peripherally, because if their palpitations have made them decompensate, then useful to look for if they've got any swelling, because it may be that they've got a murmur. It may be that they've got an arrhythmia that's pushing them over the edge. Good. Then I had PE. So PE is a bit of a weird one. Like, what would you do? What would you examine if it said this person had acute pleuritic chest pain, or you find out from the course of your history that they've basically had a PE? What examination would you do? Half pulse, lungs. Fine. All right, good. So again, if we go from the outside, so pulse useful for tachycardia. As I say, again, you already have the obs though, so it doesn't really matter what their pulse is because you've got the obs. Then the important things obviously is going to be, have they got a DVT? That's what you're going to get to at the end. That's the key thing in this station. And then I think the other things that are important would be just doing a quick listen to their lungs in case that you've missed some lung cancer or they've got a pneumonia, or that's the other reason why they're short of breath, or they've got chest pain. Obviously, you should listen to their lungs. You can also listen to their heart sounds, but I wouldn't listen in all four places. Maybe just listen in one place just to make sure they're not grossly abnormal and they've not got a massive S3. And then I think the other thing that would be worth doing is just feeling for lymph nodes. Lymph nodes are a useful thing in some of these stations because obviously if you think they've got a PE, the thing that the other important thing you want to rule out is have they got a malignancy hiding somewhere. So lymph nodes are helpful in that, in case you're missing some abdominal malignancy, chest lymphoma, for example. So I would do pulse if you want, but you already have the pulse information. So chest, lymph nodes, and then calves. Endocrine. So when I say endocrine, I mean either they've got their sodium's abnormal, their calcium's abnormal, their thyroid function's abnormal. What would be are there any specific tests you would do? Any specific examinations, sorry, you would do? If they essentially had electrolyte dysfunction, electrolyte imbalance. Hyperthyroidism, visual fields, blood pressure. Fine. So good. So if they've got hyponatremia or hypercalcemia or some other, or would be the most important two electrolyte abnormalities in the course of in looking at cancer. So in that situation, for your occult malignancy screen, if you ever think they've got a cancer, lymph nodes, just cervical is fine. Feel the abdomen to make sure they've not got hepatosplenomegaly. I wouldn't do like a full-on liver exam, but just a quick feel of the abdomen. Listening to their chest, realistically, you're never going to hear someone's got a lung cancer. So I don't think it's that useful as a test. And these tests are obviously, Sherry, these are tests are good, but these are tests. Sorry, maybe I didn't make it clear. Just I'm doing my examination. So the key things would be whether they've got an occult malignancy, lymph nodes. Their fluid status is the other thing that I think would be useful in someone who's got an electrolyte abnormality, because if they're fluid overloaded, then that's an important thing to think about as to like if they've got hyponatremia, then is that what's their fluid status is going to help you decide whether this is because of overload, underload, or the euvolemic. So looking at their legs to see if they've got any edema, and thyroid status in the course of the thyroid. And then the last thing in terms of if they've got some kind of rheum or skin presentation, in that situation, obviously if they've got a rash on the leg, you're going to look at the leg. But generally, the things to look at for that would be their whatever the history tells you, and then looking at their hands, their nails, the skin on their forearms, and then and then in terms of lungs for ILD, yeah, important, and largely that'll probably be part of their history. From the history, you'll be guided to there. Good. Fine. Next. So next is the discussion part. So you've examined them. You've taken your history, you've examined them. So now you need to discuss with the patient what you think is going on. I think some people really struggle with this because they don't do it that much in their clinical practice. And because it's quite hard, I think, sometimes to explain certain things to people in lay language that they understand. So you guys need to practice that and make that an important part of your practice. And I think it's much easier to go and find patients and just examine them. But this is the thing that people struggle with. So common diagnoses, you need to be able to say them in lay language, or you need to be able to think like, all right, this is what's going on. So if they've got electrolyte abnormality, for example, some of the salts in your blood are too high or too low, or the levels of salts in your blood are too high or too low, and we need to investigate that further. In the discussion part with the patient, I don't think you need to go into lots of detail about what investigations you're going to do. Because, for example, if you say, I'm going to check your renin aldosterone ratio, they're just going to be like, what are you talking about? So there's no benefit in saying that. I think some people try and say like all of their special tests they're going to do at this point, but I think you are at risk of alienating the patient. And instead, you can save that for when you're having your Viva part of the station, and you have time then to say those things. And that means you have less time for them to grill you about other random stuff that they like to talk to you about. So what I would say is, once you've iced them, so you say, this is what I think is going on. However, we need to do more investigations. Or if you don't know, like it could be one of these things, we need to do more investigations. These include a urine test, some blood tests, looking at your kidney function, your basic whether there's any inflammation, yada, 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 any scans, any special tests, and you need to explain that to them. Then treatment options. So you need to tell them what the treatment options are going to be for the thing that's wrong with them. And again, you need to say, and I think the important thing here is you need to be realistic and not like if you think someone's got lung cancer, for example, you can't reassure them and say, oh, I don't know, everything's going to be fine. You just say like, I'm worried that there is something serious going on, such as a cancer, and we will need to investigate further, because both in the exam and also in real life, like people appreciate honesty, so it's useful. And then if you're not sure of the diagnosis, which we're going to talk about in a second, how to address that, and always ask them what their questions are. So they have got a script and they've got at least 2 questions, maybe 4 questions. So at various points in your discussion, so before you start speaking to them, before you start talking to them about what's going on, say that you've asked them the ICE question, what are you concerned about? Or is there anything in particular that you want me to address? Then you can have your discussion, say your bits, and then say, is that clear? Do you have any questions? And then ask them again, is there anything you're worried about that I haven't addressed? Is there anything else do you have any other concerns that I can address? And if you ask them those questions, then they will just tell you what's on their script, and then you can answer it. If you don't ask them, they won't tell you, and then you'll miss the points. And like that's an important part of the mark scheme. So you just need to be really, really key on that and make sure that you leave yourself time. Like in that, when you have that 2-minute warning bell, within 30 seconds of that having been rung, you need to be making sure you're answering their questions, because that is part of the mark scheme that's really key. And often they can be like, sometimes the patients can be a bit argumentative, and that's like the point of the station, which we'll talk about later. Next. Then you have the Viva, which is just like the same as all the others. What did you find on examination? What's your differentials? Blah, blah, blah. Any investigations, management plan. I think here, so they may ask you the same question again and again and again. Like, did you find anything on examination? And if you didn't find anything, like obviously don't lie and say you did. And I think the thing to do in that situation is like, because for example, in one of my stations, which in station 5, which is the old version of this, I got full marks in that station, but the man asked me at least 4 times, did you find anything on examination? And every time I was like, no, I didn't. And he just kept asking me. And I was like, well, I must have really messed that station up. But I didn't. And I'm not sure why he asked me so many times the same question. I don't know whether they just I don't know what the reason is, like what's going through their mind. But just stick to your guns. And I think the thing that you can say, and what I said in that station at that point was, like, given that this is my main differential, I would expect to find this, or sometimes you would find this on examination, whatever it is. Or if you think at that point, oh no, they don't want to kill you. If at that point you think, oh no, I should have done this exam, or I should have looked for this and I haven't looked for it, then you can just say it at that point. So from my examination, I did not find anything, I had no positive findings. However, in somebody who's had a TIA, it may be that they have a carotid bruit, which I did not listen for. Unfortunately, I'm very sorry. They appreciate apologies, so apologize. And then yeah, and go from there. Cool. And then what do you do if you don't know what's going on? I think this is something that is not talked about that often, but unfortunately it does happen. And so you just need to have a plan for what do you do at that point, because you don't want to freeze if you don't know what the answer is. And so, and the problem is that this happens twice, right? So if you're not sure of the answer, you have to first explain it to the patient, and then you have to explain to the examiner what you think it is. And if you're not sure, then freezing is going to make you fail that station. And the problem is that obviously these stations are like heavy on the marks because they cover every parameter. So my advice, if you don't know what's going on with the patient, just talk through the differentials based on what they've told you and what your investigative plan is going to be. Like most of the investigations, if you don't know what's going to go, are not, if you're not sure what's going on, are going to be the standard things. I've done, these are my differentials. I mean, it could be this, or this. We just need to do more investigations to find out which one it is. Like the same things you would normally say if you clock someone and you're not sure what's going on. And these are the investigations that we're going to do. And then I think a useful thing to do in this situation is just pick a differential that you think is most likely, because in your mind you think, oh, this is the most likely, even though I'm not sure, I guess it could be this. And then just say, like, if this is what's going on, this is what we would do. So this would be the treatment for, like, whatever. Let's say you think this person's had a PE. This would be the treatment for a PE. And we would do this, and then we would follow you up like this. Do you have any questions? Is there anything you're concerned about that I haven't addressed? Blah, blah, blah. That way, you've shown the examiner that you know how to answer the question. You know how to do the station. You've shown them that you're empathetic. You've shown them that you know how to deal with uncertainty, and that you understand what a management plan is and how to make one, even if you're not sure exactly what you're managing in this situation. And this is like, obviously, when you're clutching at straws, but I think it can be the difference between completely failing a station and passing a station. So bear it in mind. And in the Viva, if you so we already discussed what to do if you don't find anything in examination, and then talk through your differentials and what tests you would do. And they might help you. Sometimes the examiners will help you and guide you to the answer because they know you've asked all the right questions and you just not like joined the dots. So they might say, if you give them 4 differentials and one of them is a correct one, they will often say, oh, okay, how do you manage Addison's disease? And then that means that's the answer. And so then they will just let you go and answer the question. So I think that's the good way of doing it. So as long as you have enough differentials and one of them is the correct answer, they may help you. Otherwise, they may say, do you have any other differentials? Any other differentials until you get to the answer? Because they want you to pass. Like they aren't mean. They are mean, but they don't want you to fail. They just want you to pass, having gone through their meanness. So, yeah, that's it, how they are. Cool. Good. Any questions at this point? Because then we're going to just do a couple of examples. Yep. Good. In terms of examples, so does somebody want to have a go? If not, you can just write in the chat box. All right, Tahrim, go for it. So let me unmute you. I think you're unmuted. Are you unmuted? Yeah. Yeah, I can hear you. Perfect. So you are going to take, this is your work. So this is the blurb that you get outside. Please review the 64-year-old lady who complains of a one-day history of headache. I don't know why I went here's her neurological examination to be grossly normal. And those are her observations. You're the doctor in ambulatory care. Please assess her further. So I'm going to time you. And so go whenever you're ready, go. Actually, I'll give you a minute to think about what you want to do.
Yeah, just let me make that. I go take Nano's TV. I'm coming.
But no, it's finished. On your TV. On your TV.
Sorry, that's my son.
I think he wants to have a go. So I'll give you 2 minutes to think up some questions. Yeah, he's the youngest ever. He's the youngest ever person taking the exam, Kim.
Yeah, I'm ready.
Go for it.
Hello, my name is Dr. Akram. Can you please tell me your name?
Yes, Iris Hazel.
Hi, Iris. Nice to meet you. Can you tell me your age?
Yeah, I'm 64.
Okay, so I understand your GP has sent you to me because you are having some headache. Tell me more about it.
Yeah, I've had this headache since yesterday, doctor. It really hurts. I don't normally get headaches that often, and so yeah, that's why I thought I'd see the GP. It's very bothering me a lot.
Where exactly is the headache?
It's all over my head, but I think it's a bit worse on the right-hand side.
Okay, did it come on suddenly or do you think it was more gradual?
It started yesterday morning. I think I woke up with it actually.
Okay, you woke up with it. And on a scale of 1 to 10, 10 being the highest, how much is the headache?
About 8.
Okay, is it getting worse or is it staying the same?
No, it's pretty constant, to be honest.
And how would you describe the character?
It's just like a really bad ache.
Ache. Is it going anywhere to your neck, to your jaw?
No.
Anything that made it better? Like, have you tried paracetamol or anything?
Yeah, I took some paracetamol, and maybe it made it go from like an 8 to a 7, but it was definitely still there.
Anything that's making it worse?
No, it's just not going.
What about light? Is it making it worse?
Yeah, if I look really straight at the bright lights, it does hurt more. Yeah.
It does hurt more. Okay, I'm really sorry about that. And do you think when you are leaning forward or straining yourself while you are on the toilet, it becomes worse?
No.
Okay. All right. Is this the first time you're having this headache or are you known to have some headaches?
When I was in my 30s, I used to have migraines, but I haven't had those for a long time.
Do you think this headache is different from them?
Yeah, I think so, yeah.
Okay. Have you noticed any problems with the speaking?
No.
Any nausea or vomiting?
I feel quite sick, but I've not vomited.
All right. And on roughly how much is your weight?
My weight, 70 kilos.
70 kilos. And have you traveled anywhere recently?
No, I haven't.
Okay. Do you think when you are eating food, there is difficulty in chewing food?
No, I've not noticed that.
Okay. Any pain in your sides of your head, like in temporal region?
In the which region?
I would point towards the temporal region, but in the sides of your head?
Oh, this bit of my head. No, I don't think. It does hurt there actually on the right-hand side, but it just generally hurts on the right.
Okay. Any pulsations there?
Not that I've noticed.
Any weakness anywhere on your body?
No, I don't think so.
Any neck stiffness?
No, my neck's not stiff.
Any temperature spike?
No, I've not had a temperature.
Any recent flu or cold-like symptoms?
Nope.
Any discharge coming from your ears, from your nose?
Nope, no discharge.
Okay. And have you noticed any lumps or bumps anywhere in your body?
No, no lumps or bumps that I've noticed.
Any weight loss?
No,
Any lacrimation or water coming from your eye?
no, my eyes aren't watery.
Okay, your vision is all right?
I wear glasses,
Mhm.
and I need to see the optician actually because my vision has been a bit worse, I think.
And for how long it's been?
Yeah, maybe just the last few days.
Few days. And do you think you are having problem with seeing different colors like red color?
No,
All right. Any past medical illnesses that I might be aware of?
I've got high blood pressure.
Mhm. And what do you take for it?
Amlodipine.
Okay. Are you on any hormone replacement therapies off the counter?
No, I'm not.
Okay. And do you take any drugs? It's just a standard question. Do you do any illicit drugs?
No,
Do you smoke?
not anymore.
All right. Do you drink alcohol?
Yep,
How much?
about 4 or 5 days a week.
Okay. And how much do you drink roughly?
About half a bottle of wine each time.
Okay. So our recommendation is to control your alcohol units. I will provide you further guidance about it, and we can have a chat about it once you decide to reduce your alcohol intakes. I can refer you to the appropriate services.
Does that make my headache better?
It will help towards your general health. And let's focus on your headache for now. Who do you live with?
I live on my own.
Okay, and how has this impacted you?
But I mean, the headache's really bad, so I mean, it's really hurting.
What do you do for a living?
I'm retired now.
All right. And are you able to do everything on your own normally?
Yeah, I am. I'm normally independent. I'm always out at the social club playing bingo.
Okay. Any family history of any brain issues that I might be aware of?
No, I don't think so.
All right. Okay. Thank you for answering my questions. If anything else comes up to my mind, I will ask you more questions. Is it okay if I examine you now?
Sure. What examination would you like to do?
I would like to check the pulse to see if patient is in atrial fibrillation or not. I have blood pressure with me. Then I will check.
Right, so there's no atrial fibrillation.
I will do for visual fields, visual acuity.
Sure. So your visual field. So if your visual acuity is the same in both eyes.
Okay.
And
And
visual fields.
yeah.
So I'm taking the time to do it.
Okay.
Yeah. And the visual fields are normal.
Okay. And I will offer fundoscopy as well at this point. I will do that to look for any papilledema
Sure.
and optic neuritis.
Okay, the fundoscope's not available at the moment, unfortunately.
All right, that's fine. I will send the patient for formal eye assessment anyway. And you were mentioning about the problem with the vision. Can you tell me more about it while I am examining you? And meanwhile, I will examine for brief neurological examination,
Okay.
upper limbs power, lower limbs power, planters, and quick sensation.
Fine. All of the
I will also look for temporal region tenderness.
Sure. So
I will check for proximal myopathy.
fine. So the power is normal in all of the limbs. However, you notice that there's her upper limbs are a bit stiff, both sides. There's the right hand side of her scalp is tender, over the temporal region and just generally actually, and the sensation was normal.
Thank you for letting me examine you. At this point, do you have any questions that you want to ask me?
Yeah, doctor, is it going to get better? Because it's really hurting. I'm really worried. I think maybe I've got a brain tumor or something.
That's actually a very valid concern. So there are a number of possibilities why you are having this headache. So cancer is one of the things that I want to rule out. But I'm also suspecting that there might be some inflammation in one of the blood vessels in your head that might be causing the problem with the vision and maybe leading to the headache. But I would also like to see if there is any sinister growth in there. And I will also do some more investigations to see if there is maybe some infection sitting somewhere in your brain. Okay.
Oh, okay. So that was very scary.
Yeah, it is. I'm really sorry about that. I will need to admit you while I run the investigations. And once we find out the cause, we will try to reverse it. And I'm hopeful that you will get better after that.
Okay. Fine.
Anything else you want to ask me?
Yeah, yes, doctor. And the other thing I wanted to ask you is, so, you know, like normally I'm independent. So do you think that I'm going to be independent after this all happens? Like all these things you're saying about cancer and infection, these all sound really scary.
It is difficult to commit to how you will be doing in some days, but what I have examined at the moment, I'm quite hopeful that we will be able to maintain your independence. After the admission and treatment, we will also ask our team members from the exercise specialty to come and have a chat with you and assess if you can cope at the home and see what we can do to help maintain your independence.
Sure. All right, cool. That's fine. Thank you. Great. All right. Thank you, Tareem. Good, good. So, well, now what we're going to do is I'm just going to mute you somehow.
It's fine. I can mute myself if I can find it. Yeah.
So if we go back to where we were, so we talked about, so that was good. That was really good. And you were very fast, which is always good. And you got, I think you got most of the things. In terms of differential diagnosis for everybody, so in the chat, what do you think what would you say would be your diagnoses and differential diagnoses? Good, wonderful. So I'm getting a lot of GCAs, a bit of PMR, and then migraine. No, not TIA. And then GCA in a patient with PMR. Should start with minor things like simple migraines and headaches. Fine. All right, good. So in this person, the key things were she's 64, right? It's weird for a 64-year-old to have a benign headache. She's quite old, especially that's that severe. So I think to say, so if you were going to say tension headache, you would have to put that quite low down. In terms of the main differential, so in terms of what the positive findings were headache one side of the head, which is why migraine goes high, and nausea with some photophobia. And then there was this visual thing, which we didn't really pin down. I think we could have pinned that down further. And then I said that on the examination, there was some shoulder stiffness. So I think the important thing to just say is in your history, you said any weakness anywhere. In PMR, you don't get weakness, you just get stiffness and maybe pain in your shoulders, but largely stiffness is the main problem. So what you ask is important, especially in this kind of, especially when you know what you're looking for. So if you know you were obviously thinking about GCA from the beginning because you asked me all these GCA style questions. But you need to think like, okay, does this person also have concurrent PMR? That's the first thing. And so GCA would be the main differential, and then the other differentials would be migraine, yes, important. Some kind of problem in some kind of bleed. So subarach, yeah, fine, worst headache of her life. It started when she woke up, could be definitely an answer. Migraine, yeah, you could say tension. I like that you said hangover because she drinks so much alcohol. And not stroke, but yeah, those are the main things. And glaucoma, the eye's not red, there's not like visual loss on examination, so I wouldn't go for it. And you didn't see anything weird in her eye, so I wouldn't put glaucoma really in my differential here. Then in terms of when you did your explanation, Tahreem, so you explained any stress in your life. Yeah, you can ask that. So I think in terms of when you did your explanation, I think your explanation was nice. You asked good questions about what are your concerns. The thing that I think is important to say, which you didn't do, was how are you going to manage me? So if you think they've got GCA, you need to say whatever you think your management is going to be. So we did all of this. and we'll talk about that in a second. So we talked about headaches, so you Socrates me, and then red flags for headache, which you did, I think you did all of them, which was really good. And which is fine. Then associated symptoms, so we talked about, and you did basically all of those. You didn't ask about travel. Oh, you did ask about travel. You asked about all, your history was really good. All I would say is you probably moved out of history of presenting complaint too quickly. You want to spend the most time in there. You probably could have asked me one more minute of worth of questions just to nail down the diagnosis. Yeah, morning headache. We did that. And so then in terms of other things to consider, so if we think it's GC, so then in terms of the Viva aspect of this, well, first in terms of the patient aspect of it, I think the things that they could ask in terms of their concerns would be about driving, and you should mention about whether they can drive or not, if they have visual change. So I think in this one, we didn't really have that, but driving is often a question that people ask, and it often comes up. And they may say things like, but my job is being a driver, etc. So that's something just to factor in and be aware of the normal driving rules. And then in terms of if it's an old person and they're normally independent and now they've got something that's a bit debilitating, living arrangements are important. I think the other thing that you, in your answer, just in terms of you said, oh, maybe it could be cancer, it could be infection, which is true, it could be, but I think you didn't really have any infection kind style symptoms in the history. So I think to say that is a bit premature when you've not got any reason to suspect infection, really, like an abscess. And the thing that's more likely would have been migraine. So you can say, and I think so in terms of management, acutely we're going to do these investigations. Acutely we can give you painkillers, and then because we think it's GCA, we need to give you steroids, and then the protection that goes with that. And what's I going to say to you guys? And then if we go back to this, so and these are just the standard things that they would ask you. And I think the important thing is to say that it's GCA with PMR because possibly with PMR because they've got stiffness. And in terms of what you're going to say to the person for reassurance is the investigations, management, and then follow-up. So the follow-up here would be rheumatology, and you said formal visual field assessment. I guess the last thing is, which they will pin you down on, is are you going to admit this person? So that's the question that is often the thing that people get stuck on. So what do people think based on the history that we had? Do you think this person would be admitted? Lots of yeses. Okay, let's say you have the page, let's say you have the history and you have the bloods. And the bloods, so let's say there's no visual field involvement. The blood show ESR of 100 and still headache. Admit. So I think in terms of the right answer, given this person's got really severe headache, you could say, a reason for admission could be we need to fix the headache and they're in too much pain to go home. So that's a good reason to admit somebody because they've got bad uncontrolled symptoms, which we're not fixing. I think if they just have GCA and the headache's mild and you think that it's GCA, you could just discharge them with the treatment and say, come back tomorrow for your biopsy or come back to medical ambulatory in a couple of days for a review or for a rheumatology hot clinic. Don't think you necessarily need to admit them. But I think in this case, I don't think anyone would say, oh, that's wrong, because people would admit this patient. So there's not wrong. I know all of you said admit. That's grand. I think that's fine. Wonderful. And then the OT review, I really liked how you did the physio OT thing. I think that worked really well. Excellent. Fine. And the last one I'm just going to do quickly, which is please review this 34-year-old lady with several weeks of worsening fatigue. You are the doctor in medical outpatient clinic. Those are the results. You can all just shout out some if you all write your top 3 differentials. Good combination, good selection, given that she's quite large. So I think these would be my main differentials. And I think Cushing's could definitely be in there also, given that she's obese. But these are the ones that you need to make sure that you nail questions for. So you need to, in your history, you would work through these different diagnoses and make sure you ask them like 2 questions in each one. Heavy periods, peeing more than normal, drinking more than normal, weight loss, night sweats, mood, snoring. And then examining them. So in terms of the things that you want to find on examination for someone with tired all the time. So you want to look at the why malignancy despite weight of 100. Who said that it's gain? Maybe she was 140 kilos before. We don't know. We've not asked her. Fat people can get cancer too, Jerry. Obesity is a risk factor for cancer. Exactly what was coming out of my mouth. Thank you. And in terms of examining these people, so I think the things that you need to examine are check if they're clubbed, feel their lymph nodes, do a quick thyroid exam, do they have a tremor, do they have a goiter, and then feel their tummy to see if they've got hepatosplenomegaly. And maybe you could do like a brief thyroid exam. Do they have a peripheral neuropathy or whatever? But really, you're probably not going to find anyone in examination, are you? Realistically. So you're kind of going through the motions of examining these people to make it look like you're finding, like you're ruling out these differentials. And I think the important thing here is sometimes it's not very clear what the answer is. So you need to say, so sometimes it is, but often these like vague histories, tired all the time, are not that clear. So your investigations are just standard things, urine dip, standard bloods, whether you want to do a pituitary profile as well, sure. Oximetry if you think they've got sleep apnea. And then in terms of managing them, would be a good time to say like, I am not like the differentials are wide, because if you haven't got given blood results, like you really aren't going to know. The differentials are wide. I think this is the most likely cause, or if this is the cause, this is going to be the management. For example, she's obese, let's say she's napping all the time or she's falling asleep, she has OSA. It may be that you have thyroid dysfunction, we'll do all these blood tests, or you have diabetes, but we will but I think the most likely thing is you have sleep apnea, and that's one of the tests we're going to do. If you do have sleep apnea, the treatment for that would be CPAP overnight. You can't drive until the until your sleep apnea is under control, and we'll go from there. Once we've got your results back, we'll follow you up in 2 days' time in medical ambulatory and discuss everything, because they don't need to stay here, right, for tired all the time. And then you can answer all of their questions about, oh, do you think I've got chronic fatigue syndrome, or I'm going to lose my job? And then you can just be very sympathetic and say, well, we'll see what we can do to try and find out what's going on and help you. Good. That's it. I hope that was helpful. Any particular questions? I think the important thing is that the way that they've changed the exam is such that it's going to be a bit vaguer than it was before, and you are going to, and you just need to pretend you're the med-reg, and you have 15 minutes left on the take, and you're like, oh, I've got 10 people to hand over. I want to see one more and figure out what's wrong with them. And so you just quickly see them. And in that 15 minutes, you quickly examine them, you take their history, and you order the investigations. Is that all right? And in GCA, what's the answer if I will be blind? You say, no, if we treat you early, you shouldn't be. That's all. You will get some resources during the course. And I think this is the last webinar for the course. So as we said, if you haven't already, sign up, and hopefully we'll see you all at the next course. Bye-bye.